from all those things. So moving on, as I said at the beginning that, we have a little bit of interspersed lectures because of the availability of the faculty. So although we went with the acyanotic and will be followed by Rishi, who will talk about the examination of precordium. In between, I have come with the hardware in the cath lab. Can we start? Okay. Okay. So before I start, I would like to know that how many of you have been into cath labs? Oh, quite a good. Oh, okay. So that's the beauty is that today every person, every DM who passes out, he is intervention cardiologist by default, until unless proved otherwise. Okay. So all of you are intervention cardiologists. Okay. And happy about it. And the problem is that all of you are in hurry to put a stent, do a complex case, probably do an AICD or CRT, and if time permits, if luck permits, TAVR also to be done. So that's a good goal. But I had been with all these, they are all joining us. Most of the seniors, most of us, and most of these very seniors like Dr. Palajani, Ashok Seth, and all those people, whenever I talk to them, all of them have a feeling that large majority of the cardiologists who have performed good procedures, done very good, but hardly pay any attention to the structure, construction, and the design of the material which they are using it in day-to-day practice. So I strongly urge all of you that since I can see almost all of you want to become an intervention cardiologist, please pay your attention on this lecture, because this is not only going to make you pass probably if you answer this, but more than that, it will give you an insight how you do a practice tomorrow when you're coming to the practice, and then how to go ahead with that. So with that short brief, I'll proceed. Okay, so this is the reality. So I mean, it is impossible literally to cover all the hardware of the used in cath lab. I purposely thought about the several things. I'm not going to talk about the stents, because I'm sure even if I don't talk, almost all the companies will make sure that you know about the stents. Right or wrong, that's a different story. Okay, but at least you will know what the stents are there. Guiding is important, but again, I thought it's a second thing. The most important thing is an angioplasty guide wire. I can tell you one thing is the success of a cardiologist, an intervention cardiologist, depends how he handles a guide wire. Now, after almost my 35 years of practice, I can say that the moment I see a youngster or any junior or anybody, any operator, in 20 seconds you can make out how this operator is, because it all depends on the guide wire. So I request that pay some little attention and find out what exactly is the guide wire is made up of. So what is the purpose of angioplasty guide wire? The first purpose is to track through the vessel. Okay. That means it has to go according to the bends and tortuosities and whatever is there along the vessel. So the guide wire has to go through. Then it has to access the lesion. Access the lesion may be in proximal, maybe in mid-segment, maybe in distal, maybe bifurcation, maybe fibrotic, maybe calcified, whatever may be. But we need to access the lesion with a guide wire. And to cross the lesion atraumatically. That's the most important thing. Once you are inside the lesion, it should exit the lesion atraumatically. That means it should not dissect, it should not perforate the vessel, and you should be able to get the wire out of the lesion and then take it down. And of course, the last function of it is to provide support for interventional devices like balloons, stents, microcatheters, and rotablation or whatever it is. So fundamentally, these are the 4 principles on which the guide wire works. Before I really start talking about the different guide wires, what are the few characteristics of which are pretty important? And these are often spoken, but very few really understand what exactly it means to. So let's go through that. What is our torque control? So the torque control in simple words is the amount of rotation given at the proximal end. That means at the operator, whatever is the amount of rotation he is giving it at the wire with the torquer, and how much is the rotation at the distal tip of the wire is happening. That is called the torque, or it's a torque control, because that is critically important. Because what is the length of the guide wire? Any idea? I'm sorry? 175 to 180 centimeter. And what is the length of the long guide wire? Loud, please. 280 to 400, it can be anything, okay? So it can be 200 to 280 to 290 or something. So what I'm saying is when you have such a long guide wire, so the torque control becomes a very critical point of a guide wire. Because if the amount of rotation you're giving it and it is that much amount of the tip is not moving, then the success of the procedure will be limited. Second is the trackability. What do you mean by trackability? Trackability, it is an ability of the wire to follow the wire tip. Means whenever there is a curve, there is a tortuosity, there is a bend, there is an acute bend, or there is a calcification. So the wire body has to follow the tip. If it starts buckling it, if it starts kinking it, then the trackability of the wire is not good. That is why we say the trackable means despite all that, the whole wire we could put it down where it has to go. So that's basically the body is following the tip. Steerability. Steerability, it is an ability of the guide wire tip to be delivered to the desired position. Steerable means you have crossed the lesion fine, but you don't want to leave the wire there. You have thought before it that you want to land your wire, the tip of the wire at this point. So that should be the ability of the wire, that is called the steerability of the wire. If you are not able to do that, then you have 2 problems. Either if you left it before, whichever is the position you thought about, and if you're not able to, it will not give you the support. And suppose if it has gone too much, then it will perforate a small branch. So this happens with a lot of young cardiologists. Initially, they do a good procedure, they do everything, clap, clap, clap. They have done a beautiful angioplasty, everybody cheers up, they get a party, and after 6 hours, they suddenly feel the patient is gone bad. So there is severe hypotension. You come back and you recheck the angio, and then suddenly you figure it out that when you have deployed all the material, at that time the tip of the wire progressed somewhere else and it perforated it. You didn't even notice it. So this is what happens. So steerability of the wire is critically important. Then the flexibility. So flexibility, it is an ability to bend with the direct pressure. That means whether the tip of the wire is flexible or not. I'll tell you about that also a little later. The other thing is a prolapse tendency. Tendency of the body of the wire not to follow the tip around bends. That means you imagine something like an engine with a bogies, or you can imagine it's a tractor with a trolley. If tractor engine is going somewhere and trolley is not following it, that's the thing, it's a prolapse, it's prolapsing. That means body is not following the tip of it. This is again, there is a reason for that. The prolapse, sometimes this factor can be used in various maneuvers when you really want to enter an acute angle artery. Then of course comes the radio opacity and visibility. That is very important because these are the lesser important features, but that is very important because if you are able to see where the wire is, because that radio opacity is the critical point where you can leave the wire. So that radio opacity and visibility becomes the next important point. Tactile feedback. Tactile feedback is the one which makes an operator a successful versus an unsuccessful, or a great operator versus an average operator, because I'm telling you many times you have a CTOs or you have an acute MI where there is nothing is visible beyond a left main, or sometimes left main is also gone. But still you are able to place both the arteries, the wires into LAD and circumflexes because of the tactile feel. You can feel, if you really do few thousands of angioplasties, you can easily tell, you can feel whether you are inside the artery, you are touching a wall, or you are somewhere out of it. So the trackability is again, the tactile feedback is also one of the important factor and character of the wire. So there is components which play part in tactile feedback actually. So tactile feedback of a wire is again a very important thing. Then of course the crossing, it is an ability of the guide wire to cross lesion with little or no. So that means it is the crossing of the thing atraumatically. We want every wire to cross the lesion atraumatically. That is without causing a dissection, without going subintimal, and without causing a perforation. So this, if we can achieve it by a wire, that is a successful procedure as such. And of course the support. Support is also very important. This why I'm enumerating all these points, because each and every point plays a critical role in your day-to-day practice and when you start really doing an interventions on a regular basis. Because you might have put the wire down wherever you wanted it, all was fine, but if the wire doesn't give you a support, your stent won't go. You will start thinking so many things, but wire is not supporting. You do anything. You take a guide liner, you take another inner catheter, you try to push all those things, but that's not the point. Basically, your wire selection was wrong and you're not taking a wire which can give you a support to transfer all this, whether the balloon, the stent, or the microcatheter, or the rotablation. Okay? So kindly spend some time on all these 8 factors, then start going into the cath lab. So again, I'm not going to spend too much of a time on theoretical part. I thought, I'll just cover the important things, that how basically, that's the reason I said that the structure of the wire or the design of the wire, construction of the wire is important to consider before you really jump into the field and start doing the procedures on regular basis. So it consists of 3 things. One is a core, then another is the tip, and the third is the coating. There are various ways of classifying this. Everybody does it in their own way. I have my own way, but I felt that, I'll do in such a fashion which will give you more relevant information in your day-to-day practice. So first comes the core. You can see that this is this is the major part. So this is the core, which is the structure, which can be of 2 types, 3 types. You can have a steel, you can have a high tensile steel, or you can have a nitinol. Okay, these are the 3 core materials. Now this core, the core can extend up to the tip, or it can end before the tip. So that is the reason when we say the up to the tip means it is core to the tip. Okay, body to the tip. So these are the ones when you have a core up to the tip. The advantage of that is it gives you a support, it gives you a pressure, it gives you a force. So you can penetrate, you can go into the harder lesions. But the problem is it avoids the flexibility. You don't have the flexibility of the wire. So but most of the time the workhorse wires are the ones which will be, usually they are up to the tip, except for few, 1, 2, I'll give the examples of them. Then of course, comes the tip. So the tip consists of nearly 3 centimeters to 20 centimeters of each wire consists of a tip. And usually it is basically a coil, sort of a cover, which is always over there. And this tip can be a same, that means the diameter may remain the same throughout the wire. So that is, what is the normal diameter of the wire is? What is the normal diameter of the guide wire? Okay. I couldn't hear anyone. 0.014 inch is the normal guide wire the diameter is. So either the diameter can continue up to the tip, or you can have a core, the tip can be narrower. That means the 0.14 may come down to 0.10, may come down to 0.19, 0.09, or it may come down to the 0.11 also. So the tip again can be of the same size, or it can be a narrowed one also. There is again a reason for all those things, that how it helps you in practice. And of course, the coating is the third thing. So coronary guide wires are usually 0.014 is the normal standard size. The core I already told you. The tip is usually a spring coil, okay, and it can be extended up to the tip. So most of the workhorse wires are having actually the core to the tip. So they are the core goes up to the tip. And whereas there are some wires, BMW is the commonest wire actually. Basically, it doesn't go up to the tip. That's what I was saying, that, you know, the advantage of BMW is usually a workhorse wire. I'll come to that, why the workhorse wires and other wires are. But the advantage of the BMW wire is that, oops, sorry. This is the BMW wire, when you can see that it's basically the tip, the core is ending here. It's not going up to the tip, whereas here it is going up to the tip. So this gives you the flexibility. So when it doesn't go up to the tip, you get a flexibility, and I'll show you the example. The flexibility can be utilized, especially when you have a very acute angle circumflex arising from left main. Then when you really want to enter it, you don't have to bend the wire. What you need to do is, you go there, use the advantage of the flexibility of the tip, it goes down. And that is the reason in these situations, certain wires are there. If you know the structure of the wire, you know the construct of the wire, probably you can start planning your procedure. So, and of course, the most important point is the coating. Coating I'll come, because this is what it is, the coating is. Sometimes the coating can be from here up to the point, this, or it may end just before the tip. Okay. So people have categorized into different ways, but I personally feel the wires should be categorized broadly into two categories, whether it's a polymer coated or non-polymer coated. Okay. People have a tendency, because this is a little tricky. Polymer coated wires usually on top of the stainless steel, very hydrophilic. Non-polymer workhorse wires, nitinol or stainless steel, often hydrophilic or hybrid. I want to tell you here that people think that the non-polymer is hydrophobic. No, there is a difference. Most of the non-polymer wires are hydrophilic. The polymer coating makes it extremely hydrophilic, very, very hydrophilic. And that makes the difference in procedure. So don't go with hydrophilic and hydrophobic. Hydrophobic, when it comes into water contact, it becomes like a wax. When it comes with the hydrophilic, when it comes in contact with the water, it becomes slippery. Those are all not the practical ones, because you want to use the reason why you want to use a polymer wire and non-polymer wire, I'll just go into that a little later. So primarily polymer wires are usually, it can be both, can be a stainless steel, can be a nitinol, and non-polymers are usually the workhorse wires, nitinol or stainless steel, and sometimes you have a hybrid wire also, where you have a combination of both the nitinol as well as a stainless steel, and that's basically is a run-through wire, is the one which is a combination of both. So okay, so this is one slide where I would like your attention, and because this will give you the most of the message which I want to give it, that I'm not describing you only on the numbers and whatever is the structure and other thing is enough. You know what it is. The core is made up of steel or nitinol, and there is a tip, and then after that you have a coating. Okay, it's a polymer coated or non-polymer coated. Polymer coated can be hydrophilic. non-polymer also can be hydrophilic. So basically there are two axes. One is lubricity and the penetrability is maximum with a polymer wire. And the moment you have a hydrophobic or you have a non-polymer wire, the lubricity goes out, but tactile feedback, you get it. So it's basically a play between the two things, whether you want a tactile feedback or you want a deliverability, you want a lubricity, you want to really get through the things. So you will understand once you start doing it that what exactly is your idea of doing that particular procedure is, what exactly you're looking for. If it is a chronic CT or if it is a very micro channels, obviously you will use a polymer coated wire which will go through a micro channels and it will get through the lesion. Whereas if you really find that it's a hard CTO where you really don't know and you really don't want to perforate the artery by using something, then probably you will use a forced wire, but at the same time you want the tactile feedback. So these are the things which you will get it across the time. So coming back to the non-polymer, as I said, most of the workhorse wires are non-polymer wires. What is a workhorse wire? Workhorse wire is, primarily I will suggest you, all of you, whoever is operating is, you have to select one wire which will be your patent wire for most of your procedures. You can't keep changing your wires every day, like, you know, one company fellow comes and meets you, you start using it, second fellow comes and you will mess it up. And you will not be successful, I can give you in writing. So primarily you have to have one wire which is your most dependable wire, which we call it as a workhorse wire, because you get the feeling of it, you get the sensation out of it, and you really know how to handle that wire. So most of the workhorse wires are low tip weights, unlike the heavy tip weights. Actually, in that, one of the things which I forgot to tell you is the bending of wire, because bending of the tip is equally important. The amount of force required to bend the tip of the wire is usually calculated in grams. Okay, that is how you know the most of the CTO wires are called as 12 grams, 20 grams, 3.5 grams, 4.5 grams, Gaia series and other things. Whereas the normal BMW wire, which is a workhorse wire, usually it will have a less than 0.9 grams, 0.9 grams, and usually 0.85. That is a hybrid wire. So that's what it is. Most of the workhorse wires are low tip weight, less than 1.2. And of course, the BMW and Minamo, these are the two commonly used the workhorse wires, which are usually hybrid wires. It's basically, the tip is, it doesn't go up to the tip and the tip is flexible. Whereas the other ones run through Pro Water, Samurai, and Cyan Blue. These are all the wires which basically made up of a steel. Stainless steel is the body. So again, you can see in general, most of the weights are lesser, 0.8 grams, 0.8 grams, and 0.5 grams, and Cyan Blue and Cyan. Actually, there is again a confusion between, I used to get confused with Cyan Blue, Cyan Black, and Cyan as such. But I can tell you, Cyan Blue is the one which is a non-polymer coated, with what's a Cyan Black, which is a polymer coated. And normally I'll use a Cyan Black whenever there is a CT or where I really want to slip through a wire there, I'll use Cyan Black. Whereas in Cyan Blue and other things is the one which is more, basically it's a non-polymer, but it's more safer wire, and it can go through the twists and other things, and it gives you support, because the best part of it, that is the best. I'll show you 2-3 examples of those procedures which I have done, how the wire mattered a lot, okay? And now the polymer coated, as I told, the polymer is extremely slippery in character, and you can go through the most difficult lesions, and basically it goes through a micro channels. So first line is usually Whisper. Whisper is my favorite wire. Of course, I won't suggest everybody to start with Whisper at the beginning, because Whisper is polymer coated. It's a slippery wire. If you don't have a control, you can perforate it or you can dissect it out, but it is one of the best wires, because my workhorse wire is Whisper, and majority of cases I do with that. But of course, there are Pilot 50, Cyan Black, and Fielder FC. These are for the polymers. And before I really go on to the low tip bed, I will say that what are the, I don't want to really go through too much on the CTO wires, but again, Gaia series is the one which everybody, all of you must be aware of it. Gaia is the one which is often spoken in all the meetings whenever there is a CTO things, where the thing is, it is 3.5 gram and tapered. That's the important thing. As I said, as you start tapering of the wire, the tip of the wire is tapered, so the amount of force is in a smaller area. That is the advantage of taper versus non-tapered wire. Because you can have the same amount of gram, like 3.5 grams or 4 grams Gaia, but if it is non-tapered, then it doesn't give you that force. That doesn't. So in CTOs, it doesn't really help you out. Okay. So tapered wires have this beauty of it. And of course, Judo and Miracle, you know that. Confianza Pro is our last choice. All of us use Hornet 14 because both have got the tapered as well as 12 grams and 14 grams. So not going into that too many about it, but generally, I would say that if you really want CTO wires, this is usually the classification. That's how we step up the things. And whereas if you have a polymer coated wires, the initially start the work, basically the primary line wires are these Vesper, Pilot, and Cyan Block. And low tip weight, tapered tip. In simple CTOs, Fielder XT is my choice. Fielder XT is beauty is because it is again a tapered wire. It usually comes down to 0.009. So from 0.014 to 0.009 gives you that force. And in simple CTOs, it can cross through. And heavy tape, Pilot 200 and Monango is again a very common wire. Okay, Pilot 200, a lot of my colleagues, they use it. So as I said, that basically stainless steel versus nitinol, it's basically that's the core. The advantage of nitinol is that it is kink resistant. Okay, it can take the shape and it doesn't get spoiled. That's the beauty of the nitinol versus the stainless steel. And as I said, that many times nowadays the companies are coming with a mixture of both the things. Like, you know, there are like initially I told you the Cyan and other things, they are pure stainless steel wires. Whereas you run through wire is a combination of both stainless steel and the nitinol. So that again makes the wire, gives you support as well as the flexibility also. So the wire properties, these are the ones, the trackability, flexibility, deliverability, and kink resistance. If you want all those things, so the first choice is, it is very high with polymer wire. It's usually okay with soft, low tip wires with hydrophilic and with nitinol. Whereas if it is stiff tip and heavy body, you won't get these things like trackability, flexibility, deliverability, and whether. So if you really, it has to depend on the type of the lesion which you are to cross. And according to that, probably these are the wire properties. You should keep it in mind, and then you should select your wire. Tactile feedback, as I said at the beginning, that you want to cross it, but you really want to know whether you don't want to perforate that, you're not sure about it. So tactile feedback becomes a very important point, and whenever you need a tactile feedback, so it cannot be a polymer coated. It has to have a steel, because core to tape, it will give you the force, and it will give you back the tactile sensation. And of course, if it is a tapered wire, further good. Okay. So I think I already crossed a lot of time, so I'll just go on to the clinical situations, few of them. If you have a calcified critical, soft polymer wise Vesper, as I said, Vesper in Cyan Black will be my first choice. If it is a thrombus, if it is a simple thrombus, probably any BMW Pro Water or Samurai is pretty good. But if you have a subacute thrombus, or it is an organized 4 days old MI, 9 days old MI, probably, but I always use a Vesper as my first choice. But for beginners, maybe Vesper can be a second line of choice. Okay. And of course, CTO, I don't want to really go through all those things, but because this is, don't start with a CTO ever in your practice at the beginning. But okay, this is how you go up with the Fielder XT, you start off in Gaia second, and Pilot and Confianza is the last one. So skipping few slides, and okay, I just told you that how the wire helps. Now this is the one which we did this case just 2 days before actually. Okay, now unfortunately that is not there. No, my dear, before this there was another. Oh, there's one more epicaudal view. This is okay, yeah, this is okay also. Now you can see here that it is an ostial left main, the ostial LAD with almost like, actually I wanted to show you that in epicaudal view, unfortunately it's not there. So the left main and circumflex were directed like this, and LAD you have seen, its ostial LAD is almost like a 99%, and it was at the right angles. Okay. So primarily you have to have a wire which is actually the left main, everything was directed towards the downside, and the LAD was exactly at a 90 degrees angle, and it is almost like a 99%. So that was a really challenge. So this is where you need to select your wire, because what do you do with the selecting for the such type of wire? So your tip is flexible or not, that's very important, because if you know that your tip is flexible, probably there it can bend, and before that, you can give your bends to the wire, the primary and the secondary bends. And secondary and primary bends are given according to the size of the artery. How much is the size of the, if the LAD is broader or smaller, according to that you give a secondary curve. So unfortunately I could not show you, but that would have been a nightmare to enter. But I used initially the otherwise, but this was the things. And finally, this was a simple whisper wire which easily went through, and that's how I could got it. And you can see at the beginning that, you know, I made all those bends in that. Okay. So this is what it is. Anyway, so moving on now, the second point is the guide catheters. I really will spend just 2 minutes on this. The guide catheter selection is elementary, but an issue of extreme importance, because until unless you select the guide catheter properly, until unless you give the support, your procedure will not be successful. You might cross lesion, you might do anything, but if the guide support is not there, you're gone. So guide selection is critically important. It has to sit, it has to cannulate properly. The another thing, most important thing is, any idea what is the internal diameter of a guiding catheter versus a diagnostic catheter? So I would suggest, I can give you the answer immediately, but I would always suggest please go back and go through that. It's very important. I'll show you why I'm saying that also. But anyway, keep it in mind, and I'll tell you later, okay? So the guide catheters, and often it is told in French. So again, what is this French? French is not French leave, but French is, of course, you know that Charrier, who was a urologist who did it for the urinary catheters, that's how he named it. And one French is equal to pi is equal to 3.14, or one size is equal to 1/3 millimeters. That means if it is a 6 French catheter, that means it's roughly about a 2 millimeter size catheter, and if it is a 9 French, it is a 3 millimeters. So kindly remember that, like, you know, 6 French, 7 French, and 8 French, how it is. Why? Because I'm saying is, the reason is when you measure the coronary arteries, or when you're measuring the guiding, and that is how you are assessing the stent, the balloon, or whatever it is. You must know, because that will come into millimeters. It will not come into French. So how do you know that, you know, 6 French is equal to how many millimeters and 7 French is equal to how many millimeters? According to that, you can calculate the stent size and the balloon size and other things. So that is the reason you must know what is one single French stands for. Again, the basic design of it, usually there are 3 things: lubricious, the innermost coat, then stainless steel, which actually makes the braiding, and then the outer soft nylon thing. So this is the difference, because between the diagnostic and guide, okay, the braiding is not there, so that becomes the supports are less. And again, there usually a primary curve and a secondary curve, and normally you say JL 3.5, 4, 4.5. What does it mean? Any idea? Sorry? Primary curve? Yeah, it's basically a secondary curve. So that's the length, okay. It's a 3.5 centimeters, 4 centimeters, or 4.5 centimeters. Depending upon the width of the aorta you selected. Suppose if you have a very wide aorta, naturally you will have to go with a 4 or 4.5 or 3.5. So that's the thing is, okay. And these are the different catheters. I don't want to get into those, Judkins and other things you should know. You should remember all those things before you really enter into the cath lab. So yeah, M-plus cannulation. This is one thing I will say, that AL1 is primarily for left side cannulation, but you will be surprised that most of the right coronary catheters are done with AL1 or AL2, because that's the best part. Many times the right coronary doesn't get cannulated by regular catheters, regular guides. Then what you need to do is you have to take a M-plus L1 or AL1 or AL2, spin it off the other side, and then it goes and happily goes and sits it. But not at the beginning, do it at the later on, because the problem is the M-plus is the push, it comes out, if you pull, it goes in. So that it works in differently. So out of anxiety, you think, oh, it has gone too deep, and you try to pull, it will go further down, it will dissect it. So don't handle M-plus at the beginning of it. You have to be really good at handling the things, and that is how the M-plus AL1 catheters or AL2 catheters, they go and sit. They normally go into the left side and give a spin, and then they go and sit into the right corner here. So extra backup is again for the surgery, multi-purpose, and this is the one which I would show you. Can I run this, please? Okay, this is my practical experience, and again, I'm not trying to do it. I want, please, yeah, okay, for any popularity purpose, but I just want to show you. Okay, so you can see that this is nasty left main, okay, which is completely dissected left main, and we came across this situation, and what happened is this is a diagnostic catheter, and after that we did everything possible. No guide went and cannulated. We could not cannulate any guiding. I tried everything, and by the time you can imagine, it's a left main, nasty dissection, patient's condition started deteriorating, patient had a hypotension. We had to ventilate him. He was really in a very, very bad shape. But still, unfortunately, we were not able to cannulate it with any guide. Next. Oops. Sorry. Next. Next. Okay, can you see here? Okay, so now you can see what it is. This is very strange. You are seeing a stent on a guide wire. Have you ever seen it? So this is what it is. So what happened is, we tried everything, failed. I could not by any means could cannulate, and at that moment of time patient is already in a pretty bad shape. No surgeon would touch, nobody would do anything about it. Except for the diagnostic catheter, nothing was going in. And that was a time when this helped me. The internal diameter of diagnostic catheter versus the guiding catheter. Because internal diameter of diagnostic catheter is 0.050 inch, and whereas the guiding catheter should be about 0.067 to the 0.90 inch. That is in inches actually, the guiding catheter diameter comes into. And the stent size was, we measured it, okay, it tells you what is the outer diameter of the stent, okay. It was around 0.72 inches. So I knew that by no means I can get it. So what we did is, I don't have all that thing, but I'm just telling you that we went with the diagnostic catheter. I knew diagnostic catheter is going to take a balloon through. So we cannulated the left main, we went into the left LAD. With a balloon, I have expanded the left main, got some time of 10 minutes where the patient stabilized a little bit, BP is picked up a little bit. And once the BP a little bit came to 60, 70, that's the time I took this most riskier thing, that I pulled out the diagnostic catheter with an extension wire of the normal guide wire, because I had a normal length guide wire that was 175 centimeters. That's the reason I asked you. You must be aware of what is the sizes of the guide wires are. So it was a 175, but eventually I had an extension thing, so I could extend it with another connector BMW wire, and then made it 300 centimeters. What we did is we removed the diagnostic catheter completely, and took the stent on the wire, and now you will ask me, how did you deploy it? Okay, because again, how can you deploy, which place you can deploy, because there is no way you can take an injection. So again, fortunately that day my starts were good. What I did is I told my technician and sister and everybody not to move a single millimeter also anything. So we have taken one particular place in AP Caudal, I fixed the table, did everything, took 2 bony landmarks, took the stent, deployed the stent, and after that took a diagnostic catheter. It was pretty well placed and I could save the patient. So anyway, so point is that the simple things of knowing the internal diameter of diagnostic catheters and guiding catheters has helped me to come out of that crisis. So I request all of you spend some time on basic designs, basic structure. What are the different types of stents that you forget it? Because I said every company fellow will come and brainwash you and you will become very expert in that. But knowing the basic things are very important. Thank you so much. So again, we'll have a query, question answers later only. I request Rishi. Oh, he's not there?
Check.
In the meantime, you can go with the question answers if he's coming.
Pass the mic.
Okay, so I don't think so there are any questions there. Yeah, go ahead, please. Somebody is raising the hand. Go ahead.
Please.
Hello, sir. Hello.
Yeah.
Sir, in last case, that problem was we can't able to identify where the site of location. So you said he stabilizes the table not moved. In that case, we can take other access and pigtail catheter to take a shoot.
I'm sorry, can you repeat your question, please?
Sir, last case, via guide wire we passed the stent. So the problem was to identify where to deploy the stent.
No. See, basically the problem was not there. There was no guide which was getting cannulated there. So no.
That's true. But we are not able to give injection.
Yeah.
So it is possible via any pigtail we can take aortic root shoot with other access.
Yeah, basically there could have been so many other things. See, another thing is that you do a radial artery puncture and then take a diagnostic catheter and do that. Okay. But the problem is all those things when the patient's BP is 30, 40, you really can't do all those things. Okay. So at that moment of time when the stent is already gone, because I did a POBA initially, it gave me just a 5-7 minutes of time where we could remove it. But again going there and doing a puncture with the radial artery left side or radial side, and by the time I cannulate, I lose the patient. So I had no other option but to go ahead with that. Okay. Okay. So thank you so much.